In other words, I'm just sort of talking into the slides, and it would be nice to see faces if I can.
Okay. So is there like a black box in the top left portion of your screen on the web browser?
I have a bunch of buttons on the bottom left screen. Right now, I'm only seeing the slideshow. I have to hit slide or stop sharing. Go ahead, hide.
Okay.
Back to you.
Okay. Those controls. Yeah, so if you click in the top left of your screen in Chrome, you should be able to switch views, so you can see people's faces. I can put I can't put everyone up there, but I can put a few up there.
Okay, so I'm not sure. I'm back now. Obviously, I'm not sure. So at the moment I'm not sharing my screen. I do.
Correct.
No, it's slightly. So what do I hit?
The top left, you should see like a video playing in the top left corner.
I just view and I have added bottom. Well, I'm happy just to do this with his voice only, and then, I'm sure we can figure it out. Share my screen. See my slide. Let's just work on that.
Yeah, while you're sharing your screen, you should be able to see. Dr. Zalzala's face, and then if you click on it, it can switch the views.
So I don't even see that. I only see my slides, and there's a little button that says stop sharing or hide. And then there's some buttons at the bottom.
Okay.
And then that has show presenter view screen.
Okay. Hang on.
I see you guys now, but I can't hear you.
I muted my microphone. I can still hear you.
All right, okay. You see my screen, or what do you see now?
Well, so the PACSIP interface we can get to, perhaps the Viota, does the Viota sound silent for static keywords? Kind of Viota. Let's try to Viota.
So I'm trying to get.
I wonder if we can just get started. I don't know. Paul, are you okay with not being able to see video for now?
Yeah, I'm fine.
Okay.
You see my slides now, right?
Yes.
Yes.
And I add, if you need to tell me something during the talk, just text me on my phone right here.
Okay. I wonder what we might do, Paul, is have you leave the slides up and then call in. I'm going to text you how to do that right now, okay? Because your audio keeps cutting out.
Okay, good enough.
So you call that number.
Okay.
So Robert, can he be unmuted on his phone when he calls in? And we'll use that for audio.
Yeah, I can do that for him.
Okay. So Paul,
Obviously, I muted my computer and I'm just on the phone now.
Okay, I have one says one wireless caller in the meeting right now. I don't know if that's him or not. I unmuted him.
Okay.
Okay, that sounds better.
All right.
Okay, so that is you. Okay, good.
Yeah, and if you want to mute his computer so that it's not echoing, might be great.
He needs to mute his computer.
Yeah.
You can mute him.
All right, he should be muted on his computer now.
Paul, can you test out the sound for us before you get started? Paul, can you hear us?
Is he muted on his phone now?
Hang on. I don't know. All I did was mute his mic.
Right, so he's out. Maybe he muted on his phone.
Maybe he muted. I'm wondering if he didn't mute his mic on his phone. Oh, okay.
I'm back. Yeah, I had to get a phone charger because I don't want my phone to run out of juice.
Great.
Okay. Yeah.
I'm back now. I'm charging.
Great. Okay, so I guess we can get started.
I'm ready.
Okay. All right. So should I go ahead and start my introduction?
Please. Yeah, go for it.
Okay, great. All right. So just a quick note for folks who have joined us. The CME website is down, so that if you do want to receive CMEs, you do need to send an email to continuinged@hhchealth.org in order to get your CMEs. All right. Now that's over with. Thank you all for your patience. I wanted to just take a couple minutes and introduce our speaker today. So Dr. Paul Lysaker is a clinical psychologist who's presenting to us from the Roudebush VA Medical Center in Indianapolis, where he runs the Psychosocial Rehabilitation and Recovery Clinic. This is a long-term clinic for veterans with schizophrenia spectrum disorders. In addition to his impressive clinical resume, Dr. Lysaker is a professor of clinical psychology at the Indiana University School of Medicine. He's authored over 450 peer-reviewed articles with research interests centered on psychological processes which affect disability and recovery for adults with serious mental illness, and the development of recovery-oriented approaches to psychotherapy for psychosis. He serves on the editorial board of many prestigious journals in the allied fields of mental health and has been a recipient of federal research funding since 2001. In addition to his clinical research and academic work, he's also currently the president of the Merit Institute. Over 20 plus years, Dr. Lysaker has supervised countless predoctoral psychology trainees and maintains long-term mentorship relationships with many of them by providing monthly clinical calls, consultation calls, and research meetings, demonstrating a strong dedication to training and education of early career psychologists. And beyond all of these accomplishments, Dr. Lysaker reminds us that in spite of the challenges that come as mental health providers, there's a need to integrate playfulness into our work, whether that means sending Bitmojis during meetings or finding creative ways to integrate embarrassing anecdotes about his colleagues into his professional presentations. And as one of Dr. Lysaker's previous trainees who's experienced some of these embarrassing moments, I'm very excited to be welcoming him to the Institute of Living. Today, Dr. Lysaker's presentation is titled Metacognition and Psychosis, Emerging Research and Approaches to Individual Psychotherapy. So welcome, Dr. Lysaker. I'll hand it off to you.
Okay, well, thank you so much for that kind introduction. And also, thank you for the invitation to come and speak at the Institute of Living today. I'm sorry I can't be there in person. I have ties to much of what's going on today that make this personally meaningful to me. Former close friends from graduate school, as well as former students and now friends, as well as colleagues. And I also was friends many years ago with the late Liz Webb, whose parents were both played instrumental roles in the Institute of Living. So I have many connections, and it's a pleasure to talk with you today. I think to begin with, I'll tell you my disclosures. I don't have any disclosures other than I use the same jokes over and over again, regardless of whether they seem to be funny or not. So if you've heard this before, wishing you the best. If you want to claim credit, here is the email address, and you can read from here what you need to do in order to get CE credit for this. And I will repeat this slide at the end of the talk. And I'll probably go till about 12:45, and then I'll stop for questions. So maybe what the most important slide is that if you're interested in these things, if they speak to you, if you'd like to hear more, I'm more than happy to hear from you. What you'll see above is my email address. You're more than welcome to write to me if you're interested in learning more about this or just want to talk about some of these ideas. We do have an informational website, which you can see here as well. And we have a small Twitter account. I think we have like 12 followers, or well, maybe we have more, but we have a Twitter account as well if you're interested. And please don't hesitate to contact me again if you're interested in these ideas. And I do hope this is an interesting and at least provocative, thoughtful talk for you. I'll say a little bit about what I'm hoping to accomplish here, and that is I'd like to be able to describe a model of disability for adults who have severe and persistent mental illness that enables us to see a unique role for psychosocial treatments and to see how psychosocial treatments don't just offer support or teach skills, but also can play a central role in targeting some core aspects of the disorder and play a foundational role in promoting recovery and wellness. And I'm going to offer you one example of that sort of treatment in what we call metacognition, reflection, and insight therapy, or MERIT, as we go through this. There are many colleagues who played an instrumental role in this research, and there are more than I can fit on this slide. The slide is in no order. I just sort of realize as time goes on that someone has been making a lot of contributions and their name should be here somehow. But there are more people, and I wish to at least also acknowledge that this is the work of many people, not just in the United States, but internationally as well. So let me give you an overview of, I think, how to think about perhaps disability or the suffering that goes along with severe mental illness. And I want to suggest that at its root, this suffering and disability has to do with the fragmentation or loss of cohesiveness of a person's experience of themselves and their life. They may lose a sense of cohesive thoughts. Thoughts may not fit together or fit together in odd ways. They may lose a cohesive sense of emotions, of wishes, of desires, and then ultimately experience themselves as lacking agency and possibility. They may have little sense of what they're faced with, what they want to do about it, and ultimately feel profoundly isolated from their communities. And I would begin by saying that if you think about this as sort of the foundation of disability and serious mental illness, then a door opens. And that is recovery can begin when the fragmentation begins to be resolved, when people begin to integrate their thoughts with one another, fit them together into more complex pictures, integrate emotions and desires, and then ultimately experience more coherent self-experience, experience themselves as agents in the world, experiencing themselves as having hope and possibility for the future, for realistically a fulfilling life, making sense of the challenges that are in front of them, and then ultimately feeling as if they can join the community. And I think you can see here in the area where recovery begins that this is an area where perhaps psychosocial rehabilitation can make a unique and powerful contribution to the recovery process. So this idea that fragmentation is at the root of things is not a new idea. In fact, this is the original idea of Bleuler when he first defined the concept of schizophrenia. And in fact, he used the term schizophrenia to refer to the splitting or shattering or fragmentation of the organizing things that make us comprehensible to ourselves and the world. And for Bleuler, in fact, there was an inability to integrate emotion, thought, and desire. And these were the primary problems that he saw in schizophrenia, and he in fact referred to them as the 3 A's, which in this case would be association, affect, and ambivalence. And they led to the fourth problem, which was secondary, which he referred to as autism, which is withdrawal from the world and lack of community membership. So not a new idea, but how in the world would you measure or think about this? And I think these original ideas of Bleuler make sense. They seem to have a lot of intuitive appeal. But what does it mean to integrate experience? What does it mean to not have integrated experience or fragmented experience? So the first thing I want to tell you next is that there's a way to measure this, or we propose that there's a way to measure this and instrumental and to operationalize what it means to fail to integrate information, resulting in these problems. And I'm going to use the term metacognition to talk about the processes that make integration possible. So metacognition, in terms of as a definition, involves ongoing and automatic processes that allow for thoughts, emotions, and words missing here, wishes to be fit together. And it involves synthesizing not just what you think in your mind, but also what happens in your body and the emotions that you feel. It is an intersubjective process, meaning it also doesn't take place just in our heads. So when we're integrating our thoughts or emotions or our wishes, we're always doing it in relationship to other people. And this is in some way to say that none of us ever get to decide on our own who we are. And none of us get to decide on our own just how the world is. And if you need a demonstration of this, what I would tell you is I think you well know, no one gets to decide on their own if they're funny. So I don't know about you, but in my world, if someone thinks they're funny and no one else does, it's a big problem. You also don't get to decide if you're empathic or non-narcissistic, but we are always fitting information together with other people. And that this is a multi-determined process. And it can be fueled and go awry from many different sources. So it doesn't just come automatically with the package of the human mind, but all sorts of things go into making it possible for me to integrate information and to have available a sense of who I am. And this does involve thinking about myself, but also others. And importantly, this isn't just disembodied knowledge, but we use this knowledge to decide what's going on in the world and how we want to respond to things. So intact metacognitive capacity allows us to have a sense of who we are available to us. Obviously, we don't look into our minds and see a solid object in space, but we have available at any particular moment a sense of who we are. And metacognition allows this, and this is a sense that's immediate, fluid, responsive to the world, holistic, and also multifaceted. And it is central to adaptation. This is not just some fancy thing that people do late at night sipping tea. It's something that we do in the course of life as you decide what's happening and what you want to do with your life. Our sense of who we are helps us to define problems. It helps us to decide on our own how we want to respond to them. And ultimately, it makes cooperation with other people possible. So back to the original slide, with fragmentation of self-experience or metacognitive deficits, then disability begins. And there's a lack of agency and possibility. There's a lack of comprehensible challenges. There's isolation and alienation. Also, goals don't make sense anymore. And one's whole life story may make little to no sense. So metacognition enables us to function in life. But if metacognition were to be degraded, resulting in thought, emotion, and desire becoming fragmented, then we would see a picture of disability. Now, there are related terms to metacognition, including mentalization, theory of mind, and social cognition. I think the major difference that I want to highlight is that metacognition refers to integrated information, and it is less about getting the true or correct representation of reality, because of course there isn't really one, but it's more about the ability to fit information together in an evolving way, whereas social cognition has more to do with, and theory of mind, with getting the correct image. So the major implication of this, I think, and the cornerstone of this talk, is that if deficits in metacognition underlie disability, then treatment that promotes metacognition may promote recovery when it helps people make sense of what they're up against and how they want to manage that and direct their own course towards recovery. So, fragmentation, metacognitive deficits, recovery begins with enhanced metacognition, or it can, and this could be the treatment, the target treatment, leading to desirable outcomes and ultimately self-management. So if you'd like, some of these ideas about metacognition and their role in schizophrenia are summarized here in a paper, Schizophrenia Research and Cognition. This is available online. It's free. If you just search it or go to the Schizophrenia Research Cognition page, you can download this paper. And here's a second paper that just came out recently, which you'll see I is also an author on, in Psychology, Research, and Behavior Management. This is also a free online publication. So what I want to do now with this model is I want to give you a brief overview of the supporting research for the model. I want to then talk about a treatment that could target metacognition, and then I hope to say a little bit about the research that supports it. I'm going to be a little crunched for time, So I hope I don't go too fast, but if I blur over things, there'll be time for questions, and I'm also happy to talk offline about these things as well. All right, so for us, the whole enterprise turns on the ability to measure metacognition. And in 2004, we developed something called the Metacognition Assessment Scale, abbreviated, and it was an adaptation of a different scale, but it was an adaptation that in several ways helped us to think about metacognition as a series of increasingly integrated or complex acts. And this enables us to begin to measure metacognition, and therefore we can test some of these key assumptions that I've been sharing with you. So it may be a clever idea that metacognitive deficits underlie a disability and schizophrenia, but what's the evidence for it? All right, so I'm going to pass over this. This is a slide that tells you about the elements of self-reflectivity. The slides are freely available, and we also share this scale freely as well. And I'm more than happy to send you the scale if you're interested. So first research question is, can deficits in metacognitive capacity be detected in schizophrenia? So are there even these problems in fragmentation, and can you measure them? And here's a paper that we published back in 2015. This was actually data collected in Israel that demonstrated that people with schizophrenia did in fact exhibit far greater metacognitive deficits than, quote, healthy controls or people without any kind of serious mental illness. This is a paper continuing that research now in Italy and finding that people with schizophrenia had more metacognitive deficits than those with bipolar disorder, and that people with bipolar disorder had more metacognitive deficits than healthy controls. This is a paper from data from Indiana where we again compared different clinical groups on metacognitive capacity using this metacognition assessment scale abbreviated. And here we found that patients with schizophrenia experienced far greater deficits than those with post-traumatic stress disorder, although we found some notable deficits in post-traumatic stress disorder that I can say more about if you're interested. Here we contrasted people with schizophrenia with persons with borderline personality and substance use disorder. This is published in 2017, and again found evidence of profound levels of fragmentation amongst people suffering from schizophrenia. And here's another paper where we looked at people with first episode or early phases of psychosis, and we found that they also had profound deficits in metacognition, which is to say that they had fragmented ways of being able to think about themselves and others in the world. This is published by Jen Bose in 2014. So first research finding, we do have evidence that these deficits exist. But do they relate to anything? Do they predict outcome at all? In other words, the universe of schizophrenia research is full of papers that find that people with this condition struggle in many, many tasks. And have we done more than just find another task that they struggle in? And here's a paper where we found that actually with greater deficits in metacognition, people experience their illness as more overwhelming, regardless of symptom severity. This is published by Marina Kukla in 2013. Here's a paper. This is data gathered in Scotland, and we found that poor metacognition in people with early psychosis predicted greater levels of symptoms at follow-up, and that was irregardless of the symptoms that they started out with. This is a paper by my group, published in 2015, and we again found that greater levels of metacognitive deficits predicted poor functioning going forward, irregardless of initial level of function. And here in particular, we found that metacognition predicted deficits in negative symptoms or a kind of experiential emptiness and difficulties expressing emotion. Here's a sort of blurry slide, but this is a structural equation modeling with using roughly, I think, 130 some subjects. And we're able to demonstrate a model in which metacognition predicts that people have poor functional status because it impacts intrinsic motivation. And that impact is independent of age, education, symptom severity, executive functioning, and social cognition. And I apologize for the blurriness of the slide. Oops, all right, here we go. All right. So most of this research has actually gone on in Indiana and in a few other places in the United States, but there have been replications, and you've heard about some of these already, in Italy, Israel, China, Turkey, and in a range of other settings, most recently Russia and France. There have been replications also in first episode samples. So I think we see a robust pattern in which, across cultures, people struggle with fragmented experience than as people diagnosed with a serious and persistent mental illness. And we're talking again about adults. So evidence is these deficits exist. They do seem to influence things, not just in the moment, but they predict functional problems going forward. And key question is, can you impact them or can you affect them at all? Or have we just discovered another thing that people aren't good at and another reason to not have hope? So this is actually our earliest research, and I'm going to present to you two case studies. They're intensive case studies in which essentially we looked at psychotherapy transcripts, and someone rated metacognitive capacity within the psychotherapy transcript, but not knowing whether it was the first, last, or middle transcript. And this is psychotherapy conducted by myself over 2.5 years with adults who had serious and persistent mental illness. In both cases, both have been diagnosed with schizophrenia. So the first case is a man we referred to as Grieg. He had profound neurocognitive deficits. His memory and attention were very poor. He had severe positive symptoms. He had really terrifying persecutory beliefs, and his thoughts were quite disorganized. And he and I began meeting. And obviously, you'll tell, not the usual psychotherapy patient, but he and I began meeting once a week. And again, what we did is we had someone rate the extent to which he was producing representations of self and others that were relatively complex versus more fragmented. And here's the slide. This shows you at the bottom months in treatment. This is 2.5 years. The MAS-A total score goes up and down on the side. And higher scores mean more integration. And then you'll see a 95% confidence interval fit to the line. And I think you see here compelling evidence in this one case that this man's metacognition began to increase over time. And it was slow, and it was a very herky-jerky movement in which there are gains followed by losses. In fact, it almost seems as if there's a sine wave, which is slowly tightening, in which Grieg begins to make more sense of his life, and then that falls away. And clinically, what's happening here is Grieg doesn't believe he has a mental illness. He believes all of his delusions. And there are no changes in medicine. There are no hospitalizations. But he starts to make sense of the challenges and what's happened to him. And he decides that his biggest problem in life is he's unable to love anyone. But yet he would like to love someone. To have a fulfilling life, he must find a way to love. And in fact, he does. He discovers a way to love a grandchild. Midway along the way, positive symptoms become way, way reduced. He does far more things active socially. He realizes a lot of things about his life, but more or less begins to manage it himself. And this is in spite of beginning at a spot in which he made little to no sense. It was extremely fragmented. And during this therapy, I was the therapist, I often felt inept and like I wasn't helping him, and that there was these were clever ideas, but they weren't really working. But through the lens of this research, we do see steady change. Here's a second case. We refer to this patient as Scarlatti, not his real name. He's quite a different character than Grieg. He was an extremely hostile and aggressive man who had been fired by many therapists because of his abusive language and intense irritability. He also had immense he had delusions of the grandiose nature, was also quite disorganized, and also very difficult to understand what he wanted. And here you'll see the dark line going up. This is metacognitive capacity, now put on a 0 to 100 scale. And the line going down is the severity of delusions within the session. And again, the rater is blind. And what you see here again is increasing metacognitive capacity, slowly going up, again, in an up and down way where Grieg makes gains and then loses them. And this is Scarlatti, forgive me. Grieg was the first guy. And like Grieg, Scarlatti also discovers that he has a problem in his own language, and that is that he has this intense need to be known and admired by people, and yet feels he's never done anything that should deserve such a thing. And he then goes about making sense of his life and what he's done and who he is. And delusions go down, and also the hostility evaporates. So key point, though, is that here's evidence from a psychosocial intervention, and there are no changes in medication here, that it maybe we can target metacognition, and as we target metacognition and metacognition improves, people begin to recover. And these are very real people who begin in bad ways with lots of disorganization and profound suffering. All right, so we then set apart to try to figure out what are the key elements in a therapy that would promote metacognition. And we developed this treatment. I was deeply ambivalent about naming it, but it turns out it doesn't have a name. It's hard to write about it, and no one will fund for your treatment. But the world has enough dopey treatments, each with a different name, each seeming to be brand new and yet so closely related to the others. I didn't want to repeat that. So this is an integrative treatment, and it's meant to be able to be practiced by people who do many different things. But it highlights or emphasizes the things that would enhance metacognitive capacity. And this is a photograph of the guidebook. Actually, if you buy it, it's the Rick Lautenbach promises that you'll never die and you'll always be funded. And if you hate the book, he'll give you your money back. But outside of that, it is a guidebook that describes the research that goes on, or that's gone on, as well as the treatment itself. So MERIT is an integrative practice. It's meant to actually treat real patients, people who have severe illness. It's meant to target metacognition as a capacity. And it is meant to be responsive to the ethical requirements for this work. We are working with groups with adversity who feel little agency and are easily pigeonholed and basically canceled out in the world. And this is a treatment that is fundamentally interested in promoting autonomy and recovery, and I think very responsive to these ethical requirements. So it breaks down integration into a series of distinct steps which can be assessed, and this is using the Metacognition Assessment Scale abbreviated. And then basically, therapists target patients' level of metacognition, or in other words, they assess the level of metacognition, and then they think with the patient at that level that they're at. It has core values. You have to believe recovery is possible, and not just in the abstract, but for the patient who's sitting in front of you who could be quite ill. You have to believe the patients are active agent in their own recovery, regardless of how disorganized they are. And this is often a point where we lose some people because at this point, as you probably can tell, this is not a therapy that's going to help you control anyone. In fact, it's really going to be empowering. And I think many people come into this work wanting to control and wanting to cajole, and that's not what we're interested in doing. We're interested in consulting with people and thinking with them and understanding what's happened, and allowing that this understanding may lead to pain, and also allowing that there's going to have to be the confrontation of stigma. All right. So this is how we went about trying to define it, because again, these are clever ideas, but how would you tell if they actually, if merit was happening? So we tried to come up with 8 describable things that the therapist should do. So we are describing the therapist's behaviors, and they should happen in every session. And one thing that should happen is that there should be some reflection about the patient's agenda, or what he or she really wants in the session. And this is tricky because the patient may say, oh my God, my partner is such a jerk. Or they may come in and say, I'm hearing voices. And what does that mean? Those things can mean any number of things. They can be a distraction. They can mean, help me with this. They can be, don't notice that. And what we really want to do is understand beneath what the person is saying, beneath the specific words, what are they really looking to do? And to think with them every session about what they're doing here and what they want. The second element is we want to be able to insert the therapist's mind. You have to be able to share your thoughts in a way that doesn't derail dialogue. And that may vary from patient to patient. People may only allow you to insert your mind several times, and other people may want a lot from your mind. But you've got to be a partner in dialogue. There needs to be focus on narrative episodes or the events or sequences of a person's life. This is not history gathering, but it is gaining the context for making meaning of current dilemmas and possibilities. And ultimately, what is the thing, the fourth element, the content element? What is the thing that the person is facing, or what are they up against? There should be some definition of a psychological problem. And as you probably can guess from the early the cases I presented, symptoms and diagnoses don't count as problems. Not being able to love someone, needing admiration, do. Being terrified by a delusion could. Being so consumed by a delusion you can't think of anything else and your mind is blank, that can as well. And as you can tell, these are not brand new things. Merit is not claiming to invent anything here, but these are things that need to be emphasized if we're going to stimulate and enhance metacognition. The fifth and sixth element are there needs to be a focus on the relationship, on the intersubjective processes. What is it like to talk to me? And this is not just to make sure that it's a very warm and supportive relationship, but more that it's an honest relationship, that there's actual dialogue about what it's like to talk to me or to talk to the therapist. And that ultimately there has to be attention to progress. In other words, what in the world has happened as a result of this conversation? What has changed in the mind or body of the patient? And is that good or bad? And why did that happen? And then finally, there are two superordinate principles for merit. These are the seventh and eighth elements. And this requires that when you stimulate thinking about the self or stimulate thinking about the other, that you're doing it at a level that matches the patient's metacognitive capacity. So if a person has only a fragmented sense of themselves, that's where we begin, that's where we work with. And the last is similarly with mastery, and here mastery refers to the use of metacognitive knowledge to decide how to deal with problems in life. So when you're facing a dilemma, to what extent can you use your knowledge of the world in order to decide how to respond to it? And this, of course, is more than just coping. I mean, coping, we're told, there are good and bad coping skills, or so I'm told. It's good to actively cope, and it's bad to passively cope. But of course, none of that's really true, because sometimes it's really good to passively cope and avoid things. It depends. And so this is really about knowing what to do given the situation and given who you are. There certainly are some circumstances where it is really good for me to be passive and shut up. And there are other times where it's really good for me to not be quiet and to speak my mind. And that's unique to me. And it's also unique to the people I am dealing with. And so these are the 8 elements. We have a definition of adherence in the guidebook. And when people are doing merit, we will rate the session based on a transcript or a tape. But you can also rate it yourself and decide the extent to which you are meeting or not meeting these 8 elements. And it's a just general idea about how this works, and then I'll say a little bit about the research, and then we'll stop. We're thinking about that this is, again, something that's intersubjective. We are developing a relationship with a patient and thinking with them about themselves and their lives. And that has to begin with being open to their experience, regardless of how fragmented it is, but it also requires openness to our own experience. We have to be willing to know what we feel, including our own fragmentation, our own confusion, our own anger, our wishes to nurture. All those things we have to be aware of them in our minds. It certainly doesn't mean we act on them. I may feel like yelling at a patient. It doesn't mean I should. I may feel like rescuing a patient. It doesn't mean I should. What I'm actually much more likely to do is say, I feel like rescuing you, or I feel like yelling at you. Should I be doing those things? Again, not that I will, but I need to as intersubjectivity begins, realize what's happening in me. There then, though, has to be a second side of that. So while I'm accepting fragmentation by the openness in myself and others, I'm willing to challenge people to think. I'm willing to confront them. I'm willing to be playful, and I'm willing to disclose. And I'm willing to provoke people to think a little bit about who they are in a way that's respectful, but that confirms the possibility and potential they have in their lives. And then ultimately, paralleling our earlier slide, I think then there's greater metacognitive capacity, and then we see these positive outcomes. So I'm going to talk briefly about the evaluations of merit really quick, and then we'll figure out how to deal with questions, and I'm really interested to know what you all have been thinking about this. And basically, if you don't know, I don't have a video of you, so I'm just talking into the screen. So I have no idea whether some of you have passed out or, or have become enraged or are deeply interested. So you'll have to let me know. I guess if you're passed out, you can't. Someone else could let me know. Someone appears to be passed out on the screen. So there have been some qualitative studies of merit. This is published in 2015. We basically asked people with merit versus people who've been receiving supportive psychotherapy. These are adults with serious mental illness, what it was like to receive merit. And basically what we find is that people who receive merit say uniquely some things that the supportive patients don't. And that is that it helps them think about their lives. Their history makes more sense. they can manage pain. The supportive patients report less pain, but the merit patients report they can manage pain and direct their own life. There have been several evaluations of merit. This is a randomized controlled trial of first episode patients who had no insight, meaning they denied they were ill, and we were able, this is in a 6-month trial, they were randomized to get merit or treatment as usual, and 8 of the 10 patients who were randomized to merit completed the full protocol, which is rather remarkable for this group. 2 did not, and they had to actually be removed for harassing behavior, which may have been their way of getting out of it, but at least 80% completed. And here you see some clinically meaningful and statistically meaningful gains in awareness of illness, both using the PANSS Insight Judgment Item and the scale to assess unawareness of mental disorders total score. Here's a broader clinical trial conducted in the Netherlands. This finds improvements in metacognition, but it also again shows a relatively robust group of people who are completing the therapy. And these are adults with rather serious levels of mental illness. And then there is a third paper that just came out. This is from a portion of an ongoing trial in Israel, which found, again, improvements in metacognition over the course of 6 months of psychotherapy, and these are patients with schizophrenia. And this paper went actually a little bit further and asked what merit elements seem to be linked most with gains, and actually was discussing the relationship, and the therapist sharing their own thoughts was the biggest predictor. There have been a couple of open trials as well, again demonstrating that people will accept this disorder and will show some meaningful gains. And there also have been more than a dozen published case studies, and I think these are important for a range of reasons. But not the least of those is the case studies demonstrate that this treatment can be delivered to people with very different clinical presentations in real-life settings. So my big problem with all of the new therapies that have all of the special names is they seem to be designed for patients I never meet. In other words, the patients I meet have 10,000 rule-outs, and they never would have made it into the trial for the new acronym therapy. But in these case studies, I think we see firm demonstration that real-life, complex patients can be engaged in real-life settings. So there are limitations to this. This is a developing method. Treatment is time-consuming. Not everyone can master the approach. And of course, it's not meant for everyone. Merit is not meant to be the only therapy or the best therapy. It is meant to be an approach to think about how to promote metacognition. And replication is needed, and our assessment methods are still really being developed. Again, I'm happy to share any of this with any of you. I hope this has been interesting, and I am going to pause here and am anxious to hear about any questions or thoughts that you all have. And here's your CE credit again. And I'll leave you with this beautiful picture of the book.
Thank you so much for that presentation, Dr. Lysaker. I think that was really thought-provoking. I have a lot of my own questions, but selfishly, I think it's appropriate to open the floor up for other people. So if anyone has questions, you can leave them in the comment box or shoot me an email. I know I got one email already, so I thought I would start with that question. This person wrote, this is Dr. Pollack coming from the professionals program, and she wrote, I come from an interest in the application of mentalization-based individual and group therapy for forms of pathology such as personality disorders and character pathology. Can you speak to how/if there's an overlap in the theory and or implementation of these two similar approaches?
Well, that's a fantastic question. So I think there's a very deep and interesting overlap. So we have some evidence that our system for thinking about metacognitive deficits does detect particular patterns of deficits in patients with particularly borderline personality disorder, which is where mentalization appears, to my mind, to really have begun. We share with mentalization a deep interest in thinking with people about their experience. But unlike mentalization, we're much more interested in the architecture of integration and the extent to which things move from relatively more fragmented to more integrated. And we also are, again, seeing a path to this through many different ways. So certainly a pattern of poor attachments could be associated with metacognitive deficits. But it's also possible that neurocognitive deficits or gross isolation and alienation could also lead to these sorts of deficits. I think we share with mentalization absolutely an interest in not telling patients what to think or how to think, and we share an interest in not prescribing activities in order to better thinking, but to actually do that thinking in an intersubjective context. I think one other difference is our focus on the use of metacognitive knowledge to respond to the world as separate than just self-reflectivity. So we distinguish mastery from self-reflectivity. And in fact, we find in our borderline patients that they have quite high self-reflectivity, but it's particularly the use of that knowledge that's difficult. We also distinguish from thoughts of the other the ability to think about one's place in one's community. And we again find our borderline patients able to think somewhat about the thoughts of other people, but really having a hard time seeing themselves in the larger human community. I think that you could look at what happens in merit as following a very close pattern aligned with mentalization and some of our colleagues at Austin Riggs. And we have written about the possibility of thinking about sort of interpreting mentalization through the metacognitive lens. So I hope that is a reasonable answer, but I'm happy to say more.
I wonder if anyone else, it looks like Dr. Lombach had a question in the comments there. It said, is there anything you see in your interactions with patients that helps you decide how proactive versus not proactive to be with an individual?
Well, I think that this is all about the relationship that's forming. And I really want to know what people want from me. And I don't assume that I know what they want. So when the person says, I'm hearing voices, that could mean, don't notice I'm doing drugs, help me with voices, I'm helpless, go easy on me, I'm being a good patient, tell me what to do. I spend a lot of time trying to know what someone's really telling me. And I also spend a lot of time wanting to know what it is like when I share my thoughts and what they want from me. And I review that continuously. And that shows up in the first two merit elements and in the fourth and fifth element as well. And so that exchange tells me whether I should shut up, whether I should be contradicting. I also pay a lot of attention to what's going on in my own mind. And once I know what the person wants, I also make a pretty clear idea of whether or not I'll go along with it. So if someone is trying to convince me they don't have a mind, I may not go along with that. And I may say, I want to argue with you. I think you do have a mind. Someone is just doing drugs without stopping. I may say, I feel like you're never going to stop doing drugs, and I'm not sure what my role is in all of this. I don't know what I should be doing. I certainly, when people have told me they're out of control, ask them, are you asking me to hospitalize you? Are you telling me you need to go to the hospital? Obviously, assessing dangerousness is as important as ever. And I've asked people directly, are you telling me that you're planning to hurt yourself? What do you want me to do about that? What should I do? And then, of course, I'm complete with values. I want to help people fit into their communities. I want to help them connect to people. So I'm not going to assist them to feel good about doing antisocial things. I'm not going to encourage them to withdraw and give up. And there will be ongoing and fluid conversation, and I will allow each session also in some ways to begin anew. So I will not assume that I know that we're starting off where we left off. So for example, in my sessions, I never begin with where do we finish. I never give someone a list of things to talk about. I always ask them where they want to begin, and I listen really closely to what they're saying.
Thank you. I misread Dr. Lombach's question. I think that was still useful, but he had actually asked, how do you decide how provocative versus not provocative to be? How do you...
Oh, forget me. Okay.
No, that was my mistake. I misread his question.
Well, it depends again on the person and our evolving relationship. There are people who do not want to have a playful exchange with me. They would find that playfulness insulting. There are other people who, who find playfulness helpful, that it's safer to, through play, build up something. I mean, I think there's a fantastic literature on the use of play amongst all of us as human beings. to sort of sense make and jointly figure out how to get along and be together. So the degree of playfulness will have to do with the actual person, and I think it's always provocative. When someone's mind is shut down, I always want to provoke there to be thought. I always want to know. I'm always curious. But I'm also then, I do pay attention to the extent to which my curiosity is disturbing or upsetting to the person. So I do not have carte blanche, for example, to ask people anything. Many years ago, I went to a psychoanalytic meeting, and one of the analysts, their advice was to ask all these incredibly intrusive questions of the patient, which seemed to be a disastrous misuse of power and, also just insane. So I don't have the right to ask people anything I want. It has to be jointly negotiated. So I do think that the provocation is negotiated, but I do have some values, which are, I'd like you to be healthy, I'd like you to fit into the world, and I'm not going to join with you in giving up. And I'm usually pretty clear about that up front. I remember one guy I worked with, and he said, but what if talking to you makes my voices go away? I'm like, well, I think it might. It's like, oh, so I better think seriously about whether we're gonna meet. And I'm like, yeah, sure, do it. This is serious. This is deadly serious. Take it seriously. And I think I think the playfulness does not make it less profound. In some ways, stilted seriousness is so shallow and so empty in any human relationship. That's the last thing that's needed when it's really difficult to establish a real working bond with someone where you're going to think about deeply painful and disturbing things. So I hope that was a better answer.
Yes, absolutely. I actually wanted to sort of follow up on that question that patients might ask about, what happens if my voices go away? It made me wonder about if you have any thoughts about what facilitates sort of whether it's the disruption of metacognition or the maintenance of it. So what might help in kind of so that we have a sense of why might someone be able to, why is this metacognition sort of remain, what the deficit, what creates it, and sort of what prevents it from being able to kind of be overcome or to improve their capacity?
So yes, I think you're asking both about positive symptoms and the nature of metacognitive functioning. So I guess I would say that, and this is actually an idea that it goes actually back to Bleuler, but it's also in Freud, that with the loss of metacognition comes a void. There's emptiness. Things don't make sense. And positive symptoms then fill the void. So they explain the world. They can make the world somehow fit together in a way that's a little bit better than having nothing, which is why many people then feel grief or loss when positive symptoms are eroded or are gone. I'm thinking of a guy I've worked with who refuses to take antipsychotic medication and finally took a trial of it. And he's like, I can't do this because I just don't have any thoughts now. And having some thoughts is better than none. What we see, though, in the case studies is that if you imagine that delusions are a way to explain something, as people develop better explanations, they no longer need the delusion. So it is not that people decide the delusion is false, but instead they just describe what the trials of their life are like in a more coherent way and one that enables action. So from our perspective, I could care less about symptoms. If a person is deeply concerned about them and wants to talk to me about them, I'm completely willing to do that and think about that. But I'm not there primarily deciding I'm going to ahead of time figure out what you need. But instead, the patient and I will figure out together what he or she needs, and we'll think together about it. And I will try to offer consultation on that subject. So then, the having strong or no positive symptoms it's not important for beginning therapy. You begin the same way either way. And maybe I'll say here's a quick story about this as well. So another person I've worked with who has really profound, endlessly rolling positive symptoms, which are grandiose, bizarre, paranoid, and just make no sense. What he was able to say is he doesn't think he has a mental illness, but he thinks he has memories. And the memories come to him and he's never had them before, and they occupy his whole mind, and then they screw up his ability to be connected to other people, which I think is a great set of words for what a delusion is. But it's his own words, and he discovers this himself, and then he decides how he wants to live with it. And as far as how metacognition improves, you practice it. You stimulate it and do it session after session, and people slowly get better at it. You get better at integrating information.
Thank you. I wonder if folks have questions they want to leave in the comment box or email me. I was curious too, Paul, if you might want to share a little bit about how, if folks wanted to sort of engage in this sort of treatment, how they might be able to capture or assess individuals' metacognitive capacity within the therapeutic context. Like, how do they, I know the MASA is an option that they can kind of integrate, but being able to on the moment recognize where someone's capacity is at, so they know how to intervene. If you have thoughts about ways that folks might be able to do that.
Yeah, so I think that, if there's a kind of sort of central unique quality to this approach, it requires the assessment of metacognitive capacity, and you have to be able to do it on the fly. And then you have to adjust as it changes within session. And so we have a particular scale we use. It's the Metacognition Assessment Scale. We also refer to it as the Merit Intervention Framework. And this is the tool that we would recommend that you use. If you want to learn it, when you contact me, we have a series of, we'll send you both a code book for it, but we have a series of exercises that you can do and get trained in it. So that is available for learning how to do that. If you ultimately are interested as well in attempting this sort of therapy, it is possible also to get ongoing consultation with my group as well. And I think, like any other kind of treatment like this, it is essential to be connected to other people and thinking about it with them. Because in parallel, if I'm not thinking about this outside of this work, then once I'm within it, I'll be stuck just for, falling back into habits and, stereotyped truisms.
Thank you. I don't know if you can see the chat feature, but there are a couple of comments. Dana Shagan, who's the manager of the schizophrenia rehab program, had said, thank you for the challenge, for challenging the notion that people with psychotic disorders are not candidates for insight-oriented psychotherapy. Merit seems to offer a pathway for building a narrative and making meaning from experiences. And then Dr. Lombach had written, very interesting and realistic, useful grand rounds. Thank you very much.
Well, thanks, Sean. I'm glad you found it helpful. I think this is deeply challenging work. I also think it's deeply painful work. And in some ways, the world is easier, isn't it, if we just think that our patients with severe negative symptoms are just sort of quiet and absent. But I think that this is a condition that is characterized by profound suffering and alienation. And that I think one of the biggest motivators why people want simplistic responses is that then we don't have to see the suffering that this entails, which is difficult for us. And it is a challenge.
So I know we have a few minutes left. If anybody had any last questions for Dr. Lysaker before you wrap things up. I think Dr. Choi said he might have a question, but.
Uh-oh. Is he one of the people who passed out during the talk?
Well, I guess I know that we have a couple minutes. Was there anything from your presentation that you thought maybe you'd want to go back to? I know you felt a little pressed for time. So if there's any last thoughts that you wanted to share before you wrapped up, that might be a moment to kind of wrap things up there.
I guess maybe one of the things I might emphasize is that this is a project which really involves the ongoing interaction between research and practice. So this approach really emerges because we're actively studying and trying to think about these constructs. So we don't just learn them somewhere and then go out to enact them, but we're actively trying to figure out what we think they mean and how they overlap and what they relate to. So as we're developing the research tool, we are rethinking what happens in therapy. And as we have therapy experiences, we rethink the research tool. So I think that one aspect that this brings to the fore is that it is really a process of ongoing exploration and discovery and continuous questioning. So there was the interesting question earlier about mentalization and metacognition. And I'm currently engaged in a project with a number of international colleagues, actually trying to talk about what metacognition brings to the study of self-awareness that mentalization and social cognition do not. And I'll tell you that as we write this paper, the ideas become ever clearer to me, and I think I know things because I wrote the paper that I wouldn't have known otherwise. In other words, it isn't that I think as thoughtful people we go back into our cave and know the truth and then show up and then relate it, but it's only in relating it that things emerge as true. I have a friend and colleague, Jay Ham, and we wrote a paper on supervision, and we both remarked one night after a bottle of wine and perhaps some scotch as well, we confessed that we never really understood supervision until we actually started writing about it, even though we've been doing it for years. So I think that this approach, again, it varies in that it is not, you don't go to the top of the mountain and get the truth and then go shout it out, but it really involves immersing yourself in this sort of experience and continuously trying to understand it and think about it. And I think, so that then doesn't slam the door shut on a solid sort of relic that then gets sent to the museum, but it invites any of you who are interested to think about this and really take it on. We're not looking for people to, this is, I don't know what the right word is, but this is not a religion. This is not looking for people to embrace this as the way, but instead it's a portal to thinking about some really difficult and complex human dilemmas, as well as this really amazing thing, which is our own consciousness, which somehow persists over all these years that we're alive. So maybe those will be my final remarks, unless there are other comments or questions.
That would be a great, mostly just got a couple of other thank yous and thoughts. People thought it was pretty thought-provoking and insightful. So I do appreciate you sharing. And it sounds like this has been an ongoing process of returning and making modifications and working through this. And it sounds like a model that would be great to kind of come back to and see where it is in 10 years from now. So thank you so much for presenting today. And thank you everybody for participating. And Paul, I don't know if you want to put up your information again so that folks, if they wanted to reach out to you, had their email address. That might be a good place to pause. Thank you.
All right. Go and I'll do that. Can you see that? Oops. Oh, no.
Yep, it's up. Thank you.
All right, there it is. Sorry. All right, well, I'm going to leave the screen up for a few more moments. Ayat, thank you so much for organizing this. Again, thank you all for attending. I hope this has been interesting for you.